Thank you very much. So I am Catherine Gallagher, and at the time of this study, I was a resident doctor in the Trauma and Orthopaedic Department of Altnagelvin Hospital in Derry, Northern Ireland. Thank you so much for the opportunity to present our presentation on the use of modified frailty index in spinal surgery. Frailty is considered a condition whereby individuals with frailty are more vulnerable to low-powered stressors. While chronological age and physiological frailty are separate entities, they cannot be separated completely. And with our demographic shifts, our ageing population, an increasing proportion of geriatric patients, the concept of frailty in surgery and frailty's role in perioperative complications is gaining popularity. While frailty can be assessed subjectively, to be able to adequately understand and study it, we need to use a standardized, objective approach. The Modified Frailty Index is a tool to objectively quantify patient frailty based on comorbidities. Modified Frailty Index comes as two forms, the 5-point or the 11-point scale, made up of the various comorbidities you can see behind me. The patient's comorbidities are added up and they are given a percentage frailty score. The aim of our study was to analyse the robustness of the Modified Frailty Index in predicting perioperative complication in both adult trauma and elective spinal surgery. This was a systematic review looking at all studies which evaluated the impact of increasing frailty on perioperative complication risk using the MFI. Grade criteria was used to assess risk of bias and evidence quality, and statistical analysis was completed using the chi-square test. The final review included 16 studies. We categorized frailty into not frail, pre-frail, and frail, with corresponding MFIs of 0%, 9 to 18%, and over or equal to 27%, respectively. What we found was that increasing frailty was positively associated with every outcome that we looked at. This included 30-day mortality, Clavien-Dindo grade 4 complications, which are life-threatening complications requiring ICU management, surgical site infection, urinary tract infection, reoperation rate, and readmission rate. This table shows the average percentage of patients experiencing each of these complications for our various frailty categories. And as you can see from the rightmost column, with our chi-square analysis, we found the difference between these categories to be statistically significant. Now, looking at the same data in graph form, we can see the dramatic difference between the not frail and frail patients. 30-day mortality increased from 1% to 7.7%. Clavien-Dindo grade 4 complications from 1.9 to 13.9%. Surgical site infections from 2.2 to 7.5. UTIs from 2.1 to 11.7%. Readmission rate more than doubled from 9.9 to 20%, and reoperation rate increased from 8.8 in our not frail group to 10.9% in our frail group. So, in summary, the results of our study provide a cautious endorsement for the use of MFI as a risk stratification tool in spinal surgery. Caution should be taken due to the heterogeneity of the data, the relatively small sample size, and the limited sample size. In terms of uses for MFI, potential uses lie in both the pre-operative and post-operative phases. Pre-operatively, MFI could be used as a guide to optimize patient comorbidities that contribute to frailty prior to surgery, a sort of prehabilitation, if you will. Post-operatively, to ensure that patients with higher frailty scores receive increased levels of post-operative monitoring and extended orthogeriatric care. Thank you very, very much for your attention, and thank you to my co-authors.